Our speaker today is Dr. Kerri Layman. She is the Clinical Chief of Emergency Medicine. She is Georgetown through and through, having done her undergraduate work there, or here at Georgetown, her medical education, her residency, and then her fellowship as well. She's an expert in emergency room ultrasound. But today she's going to talk on a topic that I just find fascinating, which is the care and throughput of patients who are temporarily boarding in the emergency room. And so I welcome Dr. Layman and thank her for giving grand rounds today. And with that, Kerri, please take over.
Hi, everybody. Thank you so much for inviting me. I was joking to Amron and Dr. Morrissey this morning that I'm happy this is on Zoom so that nobody can throw any tomatoes at me. I wanted to talk about boarding in the emergency department because I think it's a symptom that we deal with often, and I know it's a symptom that you all deal with as well. So without further ado, I'll kind of proceed and feel free to ask me any questions as well. Try to advance my slide. Okay. So one of the first thing I thought we should talk about is, what is a boarding hour? And so what we consider a boarding hour is basically you take the sum of the boarded patient minutes in a 24-hour period and divide it by 60, and then you get the total number of hours of boarding in the ED. And so this is a typical scene in our emergency department. There I am, probably about 5 years ago, but it honestly hasn't changed much except we've added some doors here. So essentially we have 22 emergency department physicians, 30 emergency residents, over 280 students that rotate with us, in addition to 50 nurses, 14 techs, and 4 unit clerks. And so, as you can see, we already congest the area, and then we have all of our consultants trying to see their patients. And then this is a kind of a photo illustration of what happens when the ED gets crowded. And so as you enter into the ED, you'll see, sometimes we're even giving blood transfusions in our hallway in order to try to expedite care. One of the things that's hard about working in the emergency department and the boarding compounds is the amount of interruptions that we get in a shift. And as we board patients, the number of people in our space compounds. Thus, we're often faced with more interruptions, either from patients or family or consultants or colleagues and residents and students. And so we are interrupted about 6 times more than in a primary care setting, and our average number of interruptions is 11 times an hour. Most of our shifts are about 9-hour shifts, so that's about 99 times in a shift. As a comparison, hospitalists get interrupted about 3.4 times per hour. And I have to say, I thought the numbers seemed low. I feel like we're all getting interrupted even more than that. But emergency department physicians are sort of become experts at how to handle those interruptions and continue to move through. So one of the main things that's affected with boarding is patient safety in the ED. This is one of our other hallway spaces. This is our break room in the back here. And then this here is our egress out of the department. And so you can see, when we're in this hallway space, it's actually a very concerning area, because if something happens here and you're back here, you really don't have any way out. Just this Sunday, I had a gentleman sitting in this room throw a cup of water at a nurse, and then a female who was over here threw her sandwich on the floor. A lady came out of this room to tell me that her oncologist told her it was unsafe for her to be in the ED, and she refused to go into this room. And then this is a bathroom. The lady from here who couldn't breathe, who I was really just trying to see, was trying to get out of the bathroom. So I was sort of stuck in this corner here. And we experience that quite often. So One of the things I thought I would kind of go over, because I know often people are interested in what's happening in our ED compared to the system and compared to elsewhere. So I wanted to bring you real numbers. I pulled our reports as of February of 2020 because I think it's hard to talk about boarding in the setting of COVID because in COVID, our volumes have been down. Initially, they were down to 40 to 60% of normal, but they've rebounded. Actually, we're closing in on 19% down. And so just this week, we had a record day where we had the most patients we'd seen since February of 2020 on Tuesday. We saw 107 patients. Average for us pre-COVID is about 98 patients a day. And those are new patients, not boarding patients. So our total visits were going up in February, 3.2%. And you can see from year over year, we've been increasing since 2018. Our volume had gone up 6.1%. This is our breakdown of inpatient versus observation admissions. And then you can see that we have, we continue to kind of go up. And as we go up in admissions, we realize that we're a tertiary care center. So we have one of the highest admission rates in the whole system, and actually one of the highest admission rates nationally, which is not uncommon for tertiary centers. Most ED admission rates run around 19%. We have the highest increase in volume year over year in MedStar, except this last year, Southern Maryland had a slight increase. All of the North hospitals have lost some volume in their EDs. So our volume was on target to hit 7.2% above last year until COVID hit. So what happens with this is when we hit months where we have very high volume, which is typically for us October and January, our left without being seen patient numbers go up. So we like to keep this below 3% when possible. That's our benchmark. But you can see it spikes to 7 and 5 at times. And then our left without treatment complete also spikes because of delays. We have instituted some measures that I'll go over later to help us deal with this. So one of the things that's important when we're talking about boarding is to talk about our acuity. We are not what I would call like a normal ED. We have high acuity patients. Most of EDs nationwide see a smattering that includes many more of these level 4 and 5 patients, these semi-urgent and non-urgent patients. Due to many factors, I think, our opening of many urgent care centers, and also I think long wait times can contribute as well. We don't see quite as many of these cases. We see lots of level 3 cases. Level 3 cases tend to be cases like abdominal pain that take a long time to work up. Level 2 cases are emergencies that need immediate attention. Like psychiatric emergencies, a stroke where the person is awake, and those kinds of heart attack potentially. Level 1 cases are cases that come in when the patient is coding. And so those cases tend to be less in most places. So we have a fair amount of level 2 and 3 cases. These cases, level 3 cases, they can take up to 360 minutes to work up, which means that you're looking at a 5 to 6 hour workup before you're even admitting the patient many of the time. And that's because of, waiting for a CAT scan or gathering information. Part of it is compounded by wait time, depending on what time the patient came into the department. This is a graph that I included because Dr. Welton often asks me about this. When do your patients arrive? Why do we get all these calls late in the afternoon, which I could see obviously is a frustrating thing. So when I come in the morning, if I'm working a day shift, there's not too many patients arriving no matter what day of the week it is per hour. But what happens is, usually I always tell people that rotate in the ED, sometime between 10 and 1 is when we start to grind through patients. And so we start getting lots of people in around 10 and 1, and we're trying to see them all quickly and get their workup started. So when you hit these other darker blue numbers around 3 and 4 p.m., they're stacking on these patients. And so if someone comes in, let's say at 11 a.m., you're looking at admitting them probably sometime around 4 p.m. if they needed a CAT scan or other kinds of long workups like an MRI. If it's something more simple, then we try to admit them earlier. And so Mondays and Tuesdays are our heaviest days, typically. Mondays tend to go a little bit better because we've had the weekend to decompress, so we often have beds available to move patients through to in the hospital. Tuesdays is when we really hit capacity, Tuesday late afternoon. And a lot of that is because both of these days are busy, plus the OR is busy on those days. So there's a lot of demand for beds. The other day where we tend to see a little bit of an increase is on Friday, because by then we often have many boarders in the hospital, and that tends to be when outside hospitals call and try to upgrade their patients, or they need help, or they're worried about their patients. So we tend to get a fair amount of transfers in, I would say, toward the end of the week. So one of the things that we need to work on is trying to bed people as quickly as possible during these evening hours. So a lot of times you're going to experience probably an admitting bolus around 4, 5 o'clock in the afternoon. Another thing that has affected our boarding times is we have seen a massive increase in our EMS traffic. EMS arrivals account for about 20% of our arrivals. EMS, by nature of it, tend to be higher acuity patients, so level 2 and 3 patients. They have increased significantly year on year since 2018. We saw the closure of Providence Hospital, which was an ED that treated about 67,000 patients per year. Our ED, by comparison, treats in the mid 30,000 range. So that was part of it. We saw an increase in ambulance traffic from just 2018 to 2019 alone of 40%. So ambulance patients tend to nationwide increase the length of stay in the emergency department. These are our boarding hours. So if you look at fiscal year 20, which is in the blue, versus fiscal year 19 in the yellow, we did a little bit better in fiscal year 20. And I think a lot of that I have to credit to a lot of the throughput initiatives going on in the hospital. The ED deals with boarding, but a lot of the boarding solutions are coming from others in the hospital, such as nursing leadership with bed management, as well as hospital medicine with throughput initiatives and discharge initiatives. So thank you for that. But you can see we still experience those spikes, either September, October, and then again, that January, February time period. That spike in 2019 was prior to the opening of 2 North, which has helped us a great deal. And so these are just a calculation of our boarding hours. To give you an idea, in 2019, October, we were actually running at 11,000. Which is pretty difficult for us. We typically, if you get up over 4,000 is when things start to back up. And so 7,000 and 8,000 is a high amount of hours. We see left without being seen and left before treatment complete. So basically adding on just 1 unit has helped us so much. If you think about boarding 11,000 boarding hours, just to give you perspective, if you take like our biggest, take an 18-bed unit and run it for 28 days, that's 11,000 hours. So do that at the same time that you're treating new patients coming in the door. So that's why it's a real challenge for our nursing staff to handle that, and as well as our physicians, because even though you all are caring for these patients, and thank God you are, because it's not that way everywhere, we often have to see our patients in less desirable settings due to the fact that they're all crowded in one area. And we often respond to emergencies with these patients. So these are not just regular patients either. That's a smattering of ICU, IMC, medicine, pediatrics. And the other thing to mention is psychiatric patients are not included in boarding hours because they're not technically boarding if they're waiting to be transferred to another facility because they're not in an admitted status. They account for 5% of our total volume. So it's not something to be dismissed, especially because oftentimes when the place is crowded, it can make a psychiatric patient's stay even worse. And so they often have behavioral problems that we're trying to deal with at the same time we're caring for other patients. This is an example of one of our patient satisfaction reports. So these reports are changing, as we all know, but we often struggle in the overall rating category. And part of that is because we've actually done an analysis of all the complaints we get into the ED that are actually written complaints. We have found that 48% of our complaints are related to the size and the physical plant, and 45% are related to wait time. So 93% of our complaints are not about the care the patient received in the ED. It's more about where they received the care and how timely it was. We use patient surveys, callbacks, calls to advocacy, Twitter responses to sort of collate these. So we have a patient experience committee in the ED where we actively work on these problems. Other patient satisfaction problems such as pain control, you can imagine is difficult as we work in an opioid crisis. And we try to balance the need for pain control with that. And then other things is just getting to them quickly and checking back with them. So I think our team is good, our care is good. It's just the ability to deliver it. Sometimes it's hindered by boarding. So one other thing to look at is the median length of stay in the ED. These are measures that we're benchmarked on, and these include, the problem is it also includes boarding. So even after we talk to the hospitalist or whoever's admit the patient, then the patient's still in the ED for a long period of time. And so you see it's 329 minutes. So they stay about 5.4 hours. And so if you have someone staying at 5.4 hours and then it's 5 o'clock and then even more people are coming, you kind of have to double the amount of time people are in the department, and it decreases where we can put them. This is a graph that we try to make every year because I think it really brings boarding into perspective. So if you look here, you look at the total number of hours boarded by a patient in the ED, and this is how many patients boarded for this many hours. And so if you kind of look at this graph, you can see that 50% of our patients have boarded at least 10 hours in the ED on a stretcher. And then 1 month we even had 24% of our patients in the worst boarding month we had boarded for more than 24 hours. We have not seen that this year as much. We still have patients, however, if you look down here, somebody boarded for 92 hours. So you can imagine, we're in an ED, we're at the highest boarding levels. We could have 70 patients down here all at once. We have 4 bathrooms, and they're on a stretcher. We try to get them beds when we can, but this is difficult for patients and for people trying to care for them. So why is boarding bad? We all know that ED nurse retention is a big problem nationwide. ED nurses come to EDs because they want to be involved in the initial part of care. They have high energy, they're excited, they like to do traumas and kind of stabilize patients. That's what they really like to do. So when you're filling out a lot of floor orders, I think it becomes harder for them because that's not why they usually go into emergency medicine. Patients get worse care. Heart attacks, we have delays in treatment. Luckily, we've instituted a process here where our EKGs, when done up front, our tech brings them immediately back to one of the attendings. We quickly look at the EKG, sign off on it, make sure it's not STEMI. So we at least try to get that done within 10 minutes of the patient arriving, because we know that's a possibility. Mortality goes up. There are statistics that show that if you started off your hospital stay boarding in an ED, you have an increased rate of mortality. And then MD burnout. It happens faster and it's more prevalent in areas of high boarding. So why should an internist care about ED boarding? And so some of the things that happen in the ED continue to happen to the patients when they leave the ED. So long waits in the ED lead to increased delirium. There are statistics that show that. In addition, patients who start off boarding in the ED have a longer average hospital length of stay. And there are delays. There are delays in administering pain medications, antibiotic administration. So there are lots of problems with boarding. One thing to mention is I don't want anyone to think that boarding is unique to Georgetown. Boarding happens in 66% of the hospitals nationwide in the US, and there was an advisory board report that came out in 2020, January, right before COVID hit, basically demonstrating that the boarding percentages have actually gone up. And so here are I have two slides here that detail our patient safety events. And so this is the one that happened in 2018 to 2019, and then my next slide will be later events. And so we have all kinds of PSCs. We have really good staff who tends to log them in diligently, which is great. And so our top 4 categories are typically labs, medication and fluids, diagnosis and treatment, and then finding skin and tissue problems, which is a good thing. So we had a significant uptick in the medication and fluid category when we saw more boarders. And we thought that perhaps that could be due to travel nurses or else float pool nurses coming to the ED that weren't familiar with our area. And so I have to thank our nursing leadership because they put a lot of effort into trying to train our nurses that come down to help boarding patients in the ED to our ED processes. And so I think that's gone a long way, and especially at Georgetown, to help with these safety problems. Luckily, our number of falls has seemed to go down slightly. So we have very open communication with float pool management and our nurses as well. This is the last year. And so we had a fair amount of lab errors, falls, medications, and fluids. Essentially, we have the full gamut of event types, which you could imagine in the ED, but we see an increase in them when the boarding numbers go up. So we're trying whatever we can do to try to prevent these errors and to learn from them. So if we know all this and we know that boarding contributes to problems in the ED, one of the questions we have to say is, well, why are we boarding patients in all of these hospitals nationwide? One thing that emergency literature points to is that there are wide variations in surgical schedules on different days. So often hospitals value interventional procedures, and so we see favoring those procedures on Mondays and Tuesdays. So we often have, in most hospitals, big OR days at the beginning of the week, whereas we see much less operating, obviously, at night or on the weekend. And so those swings really affect the beds available. And as you know, the OR starts early and it tends to end later in the day. So often beds are released to us late in the day. By that point, we're already behind because we've got patients stacking up in the waiting area. Another issue is the need for specialty care in our area is very high. There's barely a day on call that I go without hearing from an outside hospital that needs to send a patient to us. And so with that need, we're constantly balancing this increased influx in ambulance traffic, as well as this need to bring in patients from outside hospitals who cannot, they just can't figure out how to treat them, or they don't have the ability or the specialist they need to do it. one of the things that's started recently is the MedStar Transport initiative to help decompress tertiary hospitals and move patients into spaces in other hospitals that have room. So I think that's amazing, and I really think that that is probably going to help us going forward. However, none of our hospitals are really operating empty. So, you know, this is an area where there's a lot of sick patients, and the sick patients are really sick. You know, I get people that come to apply to work at Southern Maryland, and they think it's going to be this small little community hospital. And I'm like, no, we get really sick, complicated patients there. And so that's another area that kind of adds to the stress in RED. We also, hospitals in general, just have decreased staffing at night and on the weekend. Sorry about these little messages. This was Dr. Furlong's old computer, and I haven't gotten it under control completely. We obviously, there's less of everything, right? And so everything's running a little bit slower, you know, maybe the lab or the CT or the readings, kind of everything that adds in, you know, the number of nurses, the number of call outs, those kinds of things. And then earmarking hospital beds is another thing that's been shown to increase boarding in our emergency departments. So saying these beds are made for this patient and that sort of thing. So, you know, in our department alone, we've gotten rid of that. We've kind of taken away any specialty designation of any of our rooms and made them all flexible so that we can put any patient in any room that we need to, aside from isolation. Discharge planning problems, you know, I'm sure you all experience this. There are all kinds of logistical issues with, you know, patient transportation, planning for visiting nurses, and, you know, waiting to hear back from facilities to accept patients. And then things change, you know, often. So those things all contribute to backing patients up in the ED. So every time, you know, a hospitalist is having trouble getting a patient home or to wherever they need to go, you know, their colleague in internal medicine is calling me because their patient is in the waiting room waiting for 3 hours. So it's all connected, I think, is the lesson that we're all learning. So other things that probably are true that I've seen in the literature is there is a lot of discussion about chronically ill patients. I often say that it's pretty rare that I see a patient that hasn't been touched by our system at some point, or by another system. Luckily with CRISP, we can see just so many things that we weren't able to see before. And so there's a lot of thought that chronically ill patients a lot of the time could be managed better at home. But when they do make it to the ED, ED physicians have a hard time getting these patients back out of the ED. So patients that have a lot of chronic medical problems are really hard to discharge from an ED perspective. And then there's always this thought that some patients don't need to come to the ED. It's a controversial thought. Oftentimes, ED, you know, organizations will say, no, that's not a part of the problem. All patients need to come to the ED. But I think that we have to understand that we have to accept that there probably are some patients that would be better served, you know, with a rapid appointment or else going to urgent care or prompt care, especially now that we have such a good connection with our urgent care. And if a patient goes there and it's not appropriate, they can send them to us. So there probably is a small amount of patients who don't need to come in. The problem with that is you're relying on the patient to decide if they have an emergency. And so that's really hard. You know, patients don't know if they're having an emergency sometimes. So there will always be a large number of patients who come to the ED that probably didn't need to be there, but, you know, we can handle what's happening with them and get them set on the right track. And along with that, we have our recidivism problem. We have so many patients who I see more than I see my mother or my grandmother or really almost my own daughter. So I think that we just have people that come every day, and I know them by first name. I know a lot about them, and those people probably are not going to go away. And so that's just a problem that we contend with, and we try to get them turned around and going as best we can. But sometimes when nightfall comes, you can't really send somebody out between midnight and 5 a.m. To sit on a park bench, and so we often try to employ whatever we can. Sometimes we call hypothermia vans to drive the patients around, and we reach out to community ACT teams. We do whatever we can to try to move the patients through the ED. So how do we fix this problem? I'd probably make a lot of money if I had like a perfect fix, but I think it involves many moving parts. Right. And so one of the main things that the ED can do is risk stratification protocols. So one of the things we've instituted is something called the heart score. It helps us to figure out which cardiac patients that come in with chest pain maybe don't need to come into the ED. So we can risk stratify them to go home and follow up. And those kinds of protocols can be very helpful. We've had a lot of success with that in our department, as chest pain is one of our top 10 complaints, and it is nationwide. Moving borders to inpatient hallways. That's something that we have not been met with a lot of success, but we have met with coming up with full cap beds, which honestly is way nicer than going to another hallway. And the point of that is because research has shown that if a patient is sitting there and you see them, things are more likely to move quickly. Stony Brook is a place where they have done a lot of this research on boarding, and that's what they do. They just move 2 patients to every inpatient hallway to make room. We've come up with 7 full cap places that we use for that are much nicer than a hallway. Smoothing surgical schedules, that's something that the hospital's working on, and all hospitals nationwide are trying to work on that. And it involves a lot of math and a lot of figuring out how to balance things. Active bed management. I know, employing software we've done to look at, what beds are empty, what beds are coming up. And some of that is perfecting the way in which we know that a patient is ready to move into a bed. So I think there's still work to be done there. Discharge lounges. Discharge lounges are used in some facilities, and what happens is once the patient's discharged, we know that if we discharge patients by 11 a.m., they're much more likely to get out of the hospital. We can clean their room and use it again. But when discharges happen later in the day, because they're waiting for someone to pick them up or to get home, but they're relatively stable, some facilities have employed lounges staffed with techs or nurses or PAs, or it kind of runs the gamut, but places where patients can wait, be observed, and before they're picked up. And then aggressive discharge planning and management. I know that is being worked on because I sit on the hospital length of stay committee, and I thank everyone for how much attention they're providing to this. And there's been so much work done on decreasing the time patients stay in the hospital waiting for discharge, and just starting that discharge planning from the get-go has been just a really great change, I think. And then monitoring bed cleaning turnaround time. Sometimes it's really hard for us to tell if a bed is clean and the patients are ready to go into it. And so that's important. We need to know, we know that the bed is vacated, but we can't send a patient there until it's clean or it's been true deed or whatever. And all those things take time. And then simplifying admissions protocols. One of the problems we have is sometimes, especially in the late afternoon, a lot of our nurses, work long shifts. They work 7 to 7 throughout the hospital. And then toward the end of the day, obviously things slow down. I mean, physician productivity decreases as our shifts go above 6 to 8 hours in the ED. And so there's a concern for sign out. There's also, fatigue involved. And so sometimes our nurses will call to give report and they can't reach somebody because they're busy or whatever is happening. But kind of simplifying what you need to communicate and then getting it communicated and getting the patients moving while you're doing that is something that, you know, I think we all embrace and we're all working towards making better. And people have implemented those things at other facilities as well. And I think some fine tuning will continue, you know, as we go through this. And then reverse triage during disasters and high need times. So that's looking at the admitted patients if a disaster happens or if the hospital is full and saying, you know, which patients can move out quickly. So I think that focusing on this admission report, movement of patients, and ready to move is an area where we can all work together. So here's what we have been doing in the ED. We have a green light, red light policy. So that helps us to determine the hospital's capacity to accept transfers from other facilities. So we have found that when we have 6 or more boarders of any combination, that we are hitting the point where we're running out of space. If we have 4 ICU boarders, then we are running out of ICU space, but also resources, because it is hard to care for ICU patients in the ED when you have multiple of them and when any new one can just come through the door. And so oftentimes we'll be on red light for regular patients. We'll be on combination red light, which means ICU and regular patients are closed. And now oftentimes we're even on pediatric red light. And then we have sometimes the code bed is in the ED. And so we have to be ready to receive whatever code patient needs to come down to the ED. And so we have a process of evaluating overrides for this policy. And so sometimes there's patients for EMTALA reasons or for reasons where they cannot obtain what they need anywhere else, that we have to even override this policy and just bring the patient in to any place where we can fit them in our department. And so we often use that when a patient is critical and they really can't get care anywhere else. And so there are many ways where you can get to this. This is our main way to stem the tide for small amounts of time. And then we also have a dedicated border nurse float pool. So we can call on people to help us when we get into these situations. We have boarded, 31 patients at a time. And so we're really grateful to that. This is a new initiative that we started in the last year, ED Code Decompression. This is where we're saying, uh-oh, we're getting really full and nothing's moving. So we're seeing basically that patients are waiting over 2 hours, or there's more than 10 people in our waiting room. We have no clinical space or very limited, where we're keeping maybe 1 space open in case a code comes in. So we send an MD out front to triage. They still have patients in the back, but they're usually going toward the end of their shift, or at the beginning of their shift, and they can go up front, work with the triage nurse, try to see and discharge any ambulatory or minor orthopedic injury patients that they can get through. We can order radiology tests, point of care urine or ISTAT tests, and then we can do straight sticks. We don't like to put in IVs up there, because if people leave with IVs in, we need to call the police to track them down. We can start oral contrast for CT, which can save us an hour, and end-stage renal patients can get ISTATs as well. This is limited sometimes when physicians go on field, like tech positions, or when we have call-outs or shortages of nursing staff, but we try to enact it when we can. Let me get back here. So on average, we use this 2 nights a week. You could imagine Mondays and Tuesdays, it's common. There's usually about 13 people in the waiting room that have been waiting 3 hours and 53 minutes. And about 4 of the people will meet criteria. And sometimes we've even activated at 3 p.m. In fact, we did that this Tuesday because we hit 107 patients, which is super high volume for us. We got a lot of support from nursing as well as bed management to really help us make this work. And I'm happy to say that by 11 p.m. when the night doctor came, there were only a few patients waiting for him. Some people ask me, why don't you just divert ambulances? You know, that's been studied. And basically what happens is when you do that, you cause boluses. So we used to do that when I was a resident in the district. But what happens is when I was at Washington Hospital Center, we would get shut off for 2 hours. And then when we open back up, boom, like the whole place filled up in a minute. And so it created a lot of problem with flow. And also, patients get brought to the wrong place. You know, there was a case of an employee, I think in Wisconsin or Michigan, that was having a stroke on campus, and she got transported to a hospital far away because the hospital was on diversion, and she ended up dying. So 9 out of 10 major cities still use this, but Massachusetts got rid of it. We got rid of it, and I think things are better without having this. We can still, if there's a major crisis, like if there's a fire in the OR or something, you know, we always have the ability to call the emergency medicine person in charge in the district and get them that information. So full capacity protocol, that's what we go on when we hit the point where we have no beds and we have 6 people boarding in the ED. That's when we start moving people up to those spaces upstairs. And that's when we essentially try to avoid going on red light or get off of it sooner so we can allow our consultants to still have patients coming in. So this is the ED stretcher in Hall A. This is the full cap room. So I know many of you probably think the full cap room is terrible, but it's got to be better than this, I think. So, you know, it's not ideal, but it is better than this. So at 1 month, we saw 199 full cap patients. They spent 9.6 hours in this bed. We saw 751 boarders. They spent 15.3 hours in this bed. And so full cap is super helpful to us. We are doing everything we can to use all of our space. This is our conference room. We took the table out of it and rolled it into our office. We can see 4 patients in here at a time. This is our flex space. We redid it to fit as many chairs as we could along one wall. And then along the other wall, we have monitored spaces for admitted patients. Our normal capacity in the ED is about 43 total care spaces. And so we have had 63 patients being treated in the ER at the same time with 43 spaces, and those spaces include hallway spaces. This is, one day I came into Flex and there was all these patients boarding and this light was on just to give patients the ability to see, but also to get some sleep. And so, you know, we're really trying to do what we can. We have used our family room to see patients as well, which is normally where we talk about difficult problems with family. It's out in our waiting room. And then you've even seen this, I think now. We have put dividers inside of our patient rooms and divided them into 2 bays, a front and a back. We've added this stretcher here in front of Hall D and E, but that's right behind the attending. So, you know, that comes with all kinds of problems. Sometimes we get things thrown at us, but also in COVID, we had to get rid of this situation because they're within 3 feet of us, like where we stand for 9 hours a day. And so COVID has definitely put big constraints on where we can put patients. So just a couple words and then I'll be finished. But this is our flex space. When you walk in, you walk in through here, we have 3 rooms, 1, 2, and 3, that are all video equipped, built to deal with Ebola, but then came in handy with COVID-19. So these rooms are now being used to treat isolation patients as they have HEPA filters and are helpful for that reason. One of the things with treating patients during COVID is that we have many PUIs initially because the symptoms, as you know, are broad, but we only have 9 rooms with doors on them. So as you know, when your patients arrive to the ED, they're going to be seen in external triage. And then that's where we screen patients and decide if they're a PUI. And then they get put in the rooms with the doors and the HEPA filters. And so we try to move people through those rooms as quickly as we can because we know we're going to be using them. And so future considerations, we've got the new building coming. We are working together with early discharges. We're trying to align our ED nurse staff better to our very high churn times, meaning patients boarding, stacking on new patients arriving. We're working on throughput measures. Preparedness has really come to the forefront. We're trying to institute solutions in triage to make the most out of that area. We even have an ability to see patients on the video monitor now who do not need to be in the ED, who just have simple COVID symptoms, where a doctor can triage them and discharge them from the video. And then technology solutions, just helping us sort of wade through charts quickly and get the pertinent information that we need, I think would be helpful in the future. We also meet on a regular basis with patient placement as well as our nursing staff. We're doing everything we can. So with that, I'm really excited that we're going to be getting a new ED with more space, more patient care spaces down the road. I think that will help a lot. So thank you. And I want to say thank you so much. When I was asked to speak, I was very nervous. Most of these people are people that have taught me, and I feel like as an emergency provider at Georgetown, we have a very collegial relationship. So I thank you for your kindness, your camaraderie, your expertise, and your willingness to partner with us, even in the difficult times like now, and even when we don't get it right. And I'm sure Amron will tell me all those times. So just know that we're trying.